Well, thank you very much. For those of you who don't know me, I'm Paul Jarrett, and I am a dermatologist at Middlemore Hospital most of the time, and some of the time at the university as well. Now, I have to say, I only learnt that I was down for this talk 4 days ago. So when I'd kind of recovered from my syncopal episode, I thought, well, what could I actually do that might be of use? So I recently rewrote the acne guidelines, and I thought it might be helpful to go through that because they're available to all of you. I was also asked to just say something about referrals into the DHB. I work at counties, and we get a lot of referrals through to counties, and we're under quite a bit of pressure at the moment. That will improve because we've just had a 4th dermatologist funded for probably about 2 years' time. But in your referrals, it's better than not having one. But in your referrals, what would be really helpful is firstly detail, because we get hundreds. And when we first read, the first sentence is normal cervical smear, or immunisations up to date, or scrotum painful. Honestly, you just switch off. So if we can go straight to the nuts of the problem, that's really, really helpful. Detail is helpful. And also photographs are really useful. So we get a lot of photographs, and sometimes, a one-liner referral and a photograph that looks, like the worst rash you've ever seen. Well, that's fine. That's, reached the threshold. But the photos, if you can make them in a good light and focused as well, because a lot of them are not focused. So, we're reasonable, but we're not geniuses when they're focused. The other thing that's helpful is if you can get one of those dermatoscopic attachments to do dermatoscopic images for pigmented lesions. Because actually we can do a lot by remote control. So at the moment we're running at about 30% of our referrals are virtuals actually, so we can give advice back into the community. So just to plead, detail and really good photos, so thank you. So we have 25 minutes, and I thought I would just go through acne. And we may finish a bit beforehand, but it would be a good opportunity to have questions. And you may, perhaps could focus on Isotretinoin as well. So let's just work through it. This is I wrote them, but it's a kind of group process where they're sent out for peer review. So perhaps I don't agree with everything, but it's a very good guideline to manage acne in the community. And the first thing to say, the first message is, don't use antibiotics alone for anything. So don't just use oral antibiotics, and never use a topical antibiotic, because we're now into the days of antibiotic stewardship. And my sense is that probably fairly quickly Isotretinoin will come way down the list of things that we're going to be using, because we don't want to lose our valuable antibiotics. So the first thing, as in medicine, take a history. And really, the art of dermatology is not to place your own prejudices into somebody else's mouth. So I worked for 2 years with a world expert in acne, actually, and he showed me this person and he said to me, what do you think of this person's acne? And they had none at all. And that's a very extreme patient who has dysmorphophobic acne. It goes along like anorexia nervosa, where people are absolutely certain they've got acne and they haven't. But this person's life was wrecked. Equally, you sometimes see mums bringing in their teenagers with a face like a Domino's pizza. It looks absolutely horrendous. And you think, well, that boy needs treatment, but they don't mind. So I think it's very important you get a sense of what the patient feels about their own disease, because often your assessment may be very, very different to the patient, and even mild acne for some people can be very upsetting. So the history, age of onset of acne and its duration. So the youngest person I think I've treated was about 8, because, girls are menstruating earlier, and the oldest person I treated was about 60, But most people get acne in their lives. It's almost universal. Consider polycystic ovarian syndrome. I think that's helpful. Be careful if they have an atopic history, because if they have atopy, they're likely to have impaired barrier function in their skin. So some of the topical treatments are likely to be irritant, particularly the topical retinoids, which we'll talk about. Use of other products, especially topical corticosteroids. I have seen, unfortunately, some patients who are treated with steroids for their acne on their face, topical steroids, and of course they're comedogenic and they'll create acne. And when these topical steroids are stopped, there can be a significant rebound flare. So topical steroids are not indicated for the use of acne. Over-the-counter medications and recreational use in the gym, because sometimes you'll see these sort of Herculean athletes coming in with a bad acne, and they're using the anabolic steroids. So it's worth asking that question, because stopping the steroid would be a first route to treat their acne. And psychosocial distress, which we'll touch on in a moment again. So the examination, just if they've got acne on their face, get the gear off to look at their trunk, because you can never predict it. Most people who have acne on the face may have a bit on their trunk, or some people may have nothing on their face and their trunk can be awful. They can get diffuse acne where there are lots of little papules, or I've seen people with very severe focal acne just in the central chest, which is scarring and awful, and you wouldn't know about it unless you had looked. So look at the face and the chest and the back. And the other useful key is to do it in a bright light and stretch the skin, because you can easily see the inflammatory papules and the pustules, and you might see open comedones, the blackheads, but the whiteheads or the closed comedones are very, very difficult to see. And you need to stretch them and move the skin around. And the reason to find them is that if you don't find them, if they are not treated, the acne almost inevitably will recur. They're a marker for acne that will be difficult to treat, and probably you might need a retinoid for that. So the severity is what we think about it, and also obviously what the patient thinks about it. So mild acne. So for me, that would be acne really on the face. There may be a few comedones, some open and closed, and a few inflammatory papules. Moderate acne goes on to the trunk. And also they will fail to respond to topical treatments. And actually topical treatments generally are not used on the trunk. They're designed for the face. So if you start using topical retinoids on the chest, they're not really designed for it. Use the topical treatments for the face. And again, psychosocial distress. And occasionally acne can go down onto the buttocks as well. So if it's really extensive, go and look down into the buttock area. And severe acne, we made the point here that the definition is not solely based on physical signs and can be indicated by significant psychosocial distress. So it's not only the physical appearance, but the distress the patient feels. And it's worth asking them about that, because often they won't volunteer it. And some people's lives are blighted by this disease. So they may have papules, pustules, nodules. Some people get acne keloid, so they get acne papules that heal by keloid formation on their trunk. And actually, in our 2018, nobody really should have scarring, because that can be stopped right at the beginning with effective treatment. But unfortunately, it happens. So, the management. So, general measures. Again, some teenagers particularly will think they're dirty, and that the comedones, the blackheads are dirt. In fact, it's not dirt, it's probably oxidized melanin in them. And they will wash and wash and wash, and that really won't help them at all and will dry their skin out. Helpful to find out what over-counter medications they may be using. Water-based, oil-free facial products. In fact, you have to use really, really oily product to get comedonal and pomade acne, as it's called. It's really quite unusual to do that, but generally oil-free, water-based. Remove all makeup before sleeping, and advise against picking or squeezing. It's very tempting, isn't it, to squeeze a pimple, but all you'll actually do is force keratin and sebum into the dermis and probably make the scarring worse. So don't pick acne pimples. So the first thing about treatment for limited disease is to do it for a minimum of 3 months, a minimum. And just warn them that it's a slow disease to respond. And the other thing I have seen is that people are given a tube of treatment and then they just put it on the spots. So you want to create a field change. So make sure that all of the face is treated. So I'm very explicit with patients to put it on all of the face, go down to the angle of the jaw, rather than follow the spots around. It won't work. Don't use a topical agent. In fact, we've recommended no topical antibiotics single use in this recommendation. For comedonal acne, use a topical retinoid. So that could be either adapalene or tretinoin. And they are quite drying, actually. I quite like the creams because there's a slight emollient effect, but for cosmesis, the gel's quite nice as well. So I'll often get patients to put these treatments on at night and cover all of their face, leave it on overnight and wash it off in the morning. And one of the side effects of retinoids is drying of the skin. So that's relevant to know whether they have atopy or not, because they'll dry out more frequently. So they can put a moisture on, use sorbolene or cetamacrolol if they dry out. Benzyl peroxide's quite good, but it's unfunded. I work on the Pharmac committee and hopefully we'll get this funded at some point. There's a move to make that happen, but it's not at the moment. And start with a low strength, a 2.5. You can buy it over the counter. In fact, pharmacists will often manage mild acne themselves. You can increase the strength, but often I use 2.5 or 5, and again, for 3 months only. It can irritate. I was interested, I didn't know, but it bleaches clothes as well. So people who put the benzyl peroxide on at night and then sleep on a pillow may bleach the pillow. So perhaps that's better than during the day. Topical retinoids, we've got adapalene and tretinoin. This will personally be my first choice for mild acne, again for 3 months. I use adapalene, I think it's less irritant, but that could be challenged. Do it at night because retinoids are degraded by sun exposure, so not really good during the day. And azelaic acid, again, it's unfunded, can be useful, it can be photosensitizing. And this is the only topical combination we've put up there with an antibiotic on because of the risk of developing antibiotic resistance. And if you use the two together, that risk is minimized. So moderate acne. My first choice for moderate acne that's not scarring would be an oral antibiotic and a topical retinoid together. And Doxy is unfunded, Doxy is funded, but it's the commonest photosensitizing agent. So people can get easily sunburnt if they use Doxy. Also, it causes quite a bit of heartburn as well. So best taken at the beginning of the day and not lasting at night. Again, like the topical treatment for mild acne, do it for 3 months and then review the response. Don't prescribe antibiotics forever, and there's a cut-off we decided was 6 months. If it's not going to work in 6 months, move on and use isotretinoin. There's no point in flogging a dead horse, really. So the first line would be tetracyclines. I'd go for Doxy. Minocycline has a higher rate of autoimmune disease, so you can get minocycline-induced SLE if it's used for prolonged periods. And also minocycline can pigment the skin. It's quite interesting, it can go a slaty grey colour. And in fact, just thinking of the cardiology talk we just had, I had a patient who was on minocycline 200 milligrams for about 5 years, and he went blue. His wife thought he had heart failure. And he looked like a Smurf, if you've ever seen the Smurfs. And he had dense minocycline pigmentation, so it can be diffused or generalised. Erythromycin is quite good. You don't want to give tetracyclines to children under 12 because their dentition will be affected. And actually trimethoprim is another drug I've used when we're looking for an antibiotic to treat acne. Combined oral contraceptive pill can be useful. And the anti-androgenic ones, those that contain cyproterone acetate, can be quite useful. But I think probably here should be the heart of the discussion on isotretinoin. Isotretinoin, there aren't very many drugs that you know will work. You can tell somebody, if you take this drug, it will work. Isotretinoin is a very, very effective treatment for acne. And often the decision to use it, you can make that very quickly, but the key of the consultation is discussing that drug with them so they know what they're about to let themselves in for. So in the old days, when I was in training, we had a recipe. So we'd give 1 milligram per kilogram for 4 months, and that would be it. But of course, in biological systems, which humans are, life's not really like that. So you want to get to the biological endpoint where there are no comedones and no big acne papules. And actually, that can take 6 to 9 months. And increasingly now, we're using low-dose isotretinoin rather than high-dose. I would rarely now prescribe above 30 or 40 milligrams a day. And it's much kinder for the patient to give them a rather longer course where they feel okay than for them to feel crispy like the desert for 4 months because you happen to give them 100 milligrams of isotretinoin and it makes them fall over. Now, just mindful about the prescription, I always pregnancy test every woman, every fertile woman. Even nuns will get pregnancy tested if I treat them on this drug. Because I have actually picked up women who are just pregnant, and it's a highly teratogenic drug. So 1 tablet at the wrong time will result in a deformed baby. So I'd always recommend that you do a pregnancy test for any fertile women. And in fact, I have declined to give it to some, as I call them, giggly-gerty girls. I remember 2 came in and they were about 16 and they were, laughing away. Girl had terrible acne, but I wasn't confident enough about their discipline to take the pill. In fact, I suggest go back to your own doctor, to colleagues, to prescribe an oral contraceptive pill so I know that it is safe. Don't prescribe it with tetracyclines. I have seen patients who are swapped over or given doxy and isotretinoin and they get severe headaches with it, benign intracranial hypertension. In fact, you can get it with isotretinoin alone, and if you get that, you should stop it. Those that are taking vitamin tablets, they shouldn't take vitamin A because isotretinoin is derived from vitamin A. Don't give it to a commercial pilot because it can affect night vision, so it'll put them out of a job for a while. Not to be used with laser eye surgery. One of the problems with this drug is it will cause dry eyes. So if they're on isotretinoin and they get their eyes lasered for myopia, that can be a really bad outcome for them. And hyperlipemia is unusual, but I've had a few people whose triglycerides go up to about 10, 15, and then at risk of pancreatitis. So I do monitor lipids once. I usually do it just when they start, just before they start, and when they've been on it about a month. With women, I actually always get signed informed consent for isotretinoin. And I think if you have a reasonable discussion with a woman who knows they must not get pregnant, then I think job done, actually. And it needs to be the combined oral contraceptive pill. The implant's quite good. The condom alone really is not good enough for this medication. Mood change, again, I write this down medico-legally because all around the world, people that have prescribed this drug have had trouble medico-legally with people who have committed suicide or become depressed on it. In fact, the latest meta-analysis I read of this drug suggested that there was no risk. But of course, if you need to have a balanced discussion with them. So I tell patients that if you feel low, stop the drug. The other thing you have to remember is that acne makes people low as well. So I've actually given it to people who I know were depressed because of their drug, and they feel great. You can see a teenager coming in mopey with long hair over their face, and when they come back, they're happy people. So just remember that disease itself can cause depression, and the jury's out still really about this. But medico-legally, I always write the risk of depression discussed with the patient. And if there's doubt, just stop it. One of the key things about this drug is the way you start it. So never start with the full dose. Always start with a low dose, because it actually is a gentle introduction. So people who have really bad acne can have a significant flare when the isotretinoin is started. So if they're covered in papules or pustules and you give them isotretinoin, it will make it worse. So you can predict those people who are likely to flare. So when it's really awful, actually I've started them on systemic steroids and then introduced isotretinoin slowly. Or I've started them with an oral antibiotic, and usually I'd use erythromycin to bracket the introduction of isotretinoin, because the flares can be terrible. And again, there has been medical legal activity around this where people are unaware it's going to happen and the scarring is worse than it may otherwise have been. So start gentle and work up. And actually, I tell patients, find the dose that suits you. So it might be 20, 30 or 40 milligrams a day, and they can up it or down it. And provided they are routinely checked and you can just assess their progress, to a degree they can control their own dose actually. Make sure they have a lip balm, because the lips can get quite crusty cheilitis on it, and a moisturiser. If it's too much for them, just reduce the dose so it's comfortable. It's quite good at sunburning people, so beware of sun sensitivity. Having said that, I prescribe it all through the year, but just tell them to take care in the summer. Skin fragility is quite interesting. Those of you that prescribe acitretin for psoriasis, you can often know that they're on it, because when you shake their hands, it has a softening and a feel to the skin, because the skin becomes softer and more fragile, so it can tear more easily on this drug. And related to that is paronychia. So some people on this drug get toenail paronychia, and it's often forgotten that isotretinoin can cause that. So if they get paronychia, just stop isotretinoin and let the paronychia settle. Be careful with contact lens wearers as well, it can be quite irritant. People who have atopic eczema, you need to be very careful with isotretinoin. It can flare it significantly. Even a low dose of isotretinoin can flare atopic dermatitis. And musculoskeletal pain as well. It's quite interesting. I'm very careful with athletes when I'm prescribing this drug, because they can get significant muscular aches and pains. It's more common actually in older patients who are in their 30s or 40s who need this drug. Which just does lead me to another point, that we're recognising that the demographics of acne are changing. And although teenagers get it, often women as a group in their late 20s and 30s will get it. And those people don't tolerate acne at all. And isotretinoin is a really good treatment for them. So let's just see, we're nearly there. Get consent. I would recommend, what have we done? Get a written consent and put it in the notes so that you've covered the most important things about it. Blood tests, I always check blood tests before, and generally, personally, I check it about 4 weeks after starting. And I don't personally recheck them unless there's a good indication to do that. And the duration of the course is to keep going until they're better. So somebody with horrendous, awful acne might need 18 months. Somebody with mild acne with significant psychosocial distress might get away with 6 months. And one of the problems with those people is stopping the drug, because they really like not to have acne. And in fact, I have done that and allowed them to continue, because it takes away that sense of stress that they feel. Well, actually, it's 4:30. So that's an ad-lib talk for you in 25 minutes. And
Thank you very much.